On the exam, what I'm going to do is give you a scenario, and you're going to have to tell me if the person meets the criteria for a disorder, and if so, which one it is. Knowing the duration of symptoms, about social, occupational impairment, functioning. A few specifiers. We talked about comorbidity before you left last week. In some of the cases, we talked about suicide. That said, if you look on your outlines, anything outside of the diagnostic criteria is for you to read. You're going to see it again on the exam. Know all the factors. This textbook comes from the perspective of kind of a neurobiological potential cause or a cognitive cause. Those are the two. When we talk about genetic factors, they range between 0 and 1. We look at twin studies. We look at identical twin studies in particular. And we usually see anything that's 0.4 or above is considered statistically significant. That means it's probably not due to chance. When we look at anxiety disorders as a category, that they're anywhere from 0.2 to 0.4. Some of those findings aren't significant at all. Some of them are just about reaching that 0.4. However, panic disorder of all of them seems to be the highest, and that comes in around 0.5. If it doesn't seem to be as strongly genetic as some of the other disorders we'll discuss this semester, what does that say about the more environmental, more learned? Specific phobias basically happen with someone not realizing classical conditioning is going on. We could prevent them. We could also treat them very well with therapy. These are psychotherapeutic techniques that have been proven to work. So they're empirically supported. There are some neurobiological factors that seem to underlie some of these anxiety disorders. There seems to be 3 neurotransmitters in particular. So we had serotonin, norepinephrine. Norepinephrine, if you don't know, it's a neurotransmitter involved in arousal. Your vigilance is very, very high, and that either could be the cause of the anxiety or that could fuel anxiety. We're not really sure which one. GABA. GABA is a neurotransmitter that helps to control anxiety, and it's got a calming impact on us. It's what we call an inhibitory neurotransmitter. It kind of slows things down for us. Also discussed in your textbook is what we call the fear circuit. Do you see these 2 little blue things? 2 little almond-shaped structures inside the brain. Those are called the amygdala. Humans and animals. The amygdala, when stimulated, immediately responds with fear. It is no surprise that we know the amygdala is going to play a role in anxiety disorders, and certainly we see that. Our hippocampus is strongly involved in these anxiety disorders as well. So the amygdala communicates with the hippocampus. Our amygdala always wants to respond with fear and anger. It accesses memories from the hippocampus. Remember I gave you the example of my cousin with the spider? Okay. Clearly that phobia, that fear of hers, was learned somewhere along the way. Absolutely terrified of this little thing that cannot hurt her. But do you see where her amygdala was activated? Because she responds to this intense fear. So the hippocampus is going to be activated. We have what's called the medial frontal cortex. Part of our frontal lobe calms us down. It reasons with us and says, hey, there's really no reason for us to have this extreme reaction to this little spider. The spider's not going to hurt us. What we call generally our fear circuit. The whole point is this. People with anxiety disorders, their fear circuit is not working like we would expect it to work because their medial prefrontal cortex isn't able to modulate and keep under wraps that irrational fear. Research shows on different scans that people with anxiety disorders seem to have higher than normal activity in their amygdala. Research also shows that people with anxiety disorders, their medial prefrontal cortex has less activity than we would expect. However, it's more than just biology because there is a cognitive factor involved. People with anxiety disorders are much more likely to think that bad things are likely to happen. What is the likelihood? What is the probability? Possible and probable? Good way to help talk someone through their anxiety. You have to acknowledge, are bad things possible? Yep, absolutely they are. Are they probable? Are they likely? Statistically, what is the likelihood that that bad thing might happen? This is a part of our frontal lobes trying to help us reason. Random things happen, and it's terrifying, and it's scary, and it's tragic sometimes. But when we look at the probable comparison, that should bring down our anxiety. a completely different way of looking at what causes anxiety disorders. Here we're looking at someone's cognitive style. Here we're looking at their biology. If you feel like you don't really have much control over your life, that predisposes someone to anxiety disorders. When people experience trauma, they are much more likely to feel like they don't have very much control, especially childhood trauma. If you experience something horrendous in childhood, based on the research, are far more likely to believe that you really don't have very much control over things. And then you just bring that way of thinking with you. Past trauma, child abuse, we know for certain that that leads to this perceived lack of control. These are correlational. These are things that tend to go hand in hand, but they do not predict each other. When someone is raised in a very strict household where they are not allowed to make decisions, they are not allowed to be autonomous, A, they never learn to be independent, and B, when they become 18 and we send them off to school, and that is overwhelming, and that is anxiety producing. What could cause that perceived lack of control? A lot of things, but the research really focuses on trauma, childhood abuse, and this really stringent rearing style, which we don't want to be too hands-off because that causes anxiety too. Last thing, people with anxiety disorders are more likely to pay attention to negative cues and threats. So my point is, it is all intertwined in very complex ways, which is why there's not always like one simple answer. People with anxiety disorders generally as a group are less impulsive. If you look under etiology, there's not one specific cause for all of these. We talk about multifinality. There are many pathways that can lead to the development of that disorder. Multi-causal, multi-pathway. Multifinality, meaning multiple causes can lead to one final diagnosis. That brings up the discussion of treatment. Because there's a lot of causes, there's not one treatment that's always going to work with each disorder. It depends on what's causing that person's disorder. So if I'm working with someone with an anxiety disorder, A, it depends on what the anxiety disorder is. That will dictate treatment. And B, what's underlying that particular person's anxiety disorder. The person's situation will dictate which treatment would be the best option. Treatment falls into two categories. We have therapy, we have medication. Sometimes we have a combination of both. The cognitive therapy is outstanding in terms of treating anxiety disorders. And if someone can get cognitive therapy, it's not a temporary fix. These are tools that a person learns, can help them resolve the condition. Okay, so cognitive therapy, research shows, works very effectively. However, not everyone's insurance pays for therapy, even though it's supposed to, or sometimes you just can't even find a good therapist. So medication is another option as well. The therapies that seem to work, based on research, seem to have the same thing in common, and that thing in common is during the course of treatment, there's exposure. Speaking, medications that we use to treat anxiety disorders are called anxiolytics. Anxiolytics are medications used to treat anxiety disorders. Sometimes they're called anxiolytics, sometimes they're called anti-anxiety medications, sometimes they're called minor tranquilizers. Sometimes they're called sedatives. So we have two general types. We have the benzodiazepines, and then we actually have the antidepressants. So under the category of benzodiazepines, we have medications like Xanax, Ativan is another one, which are anti-anxiety agents, so we can call them anxiolytics. Benzodiazepines work very, very, very well, and they work very quickly, within about 20 minutes. They slow down your central nervous system. So the benzodiazepines, they work really, really, really well. But we have to be very careful because these have a very high addiction potential. It's going to be short term. People generally are not on benzodiazepines over the long term because of the concern of addiction. They found by accident that the antidepressants actually work remarkably well for anxiety disorders. They were doing research on people with depression, and a lot of the people with depression, in a particular research study, also had anxiety. And so when they were in this research study to see if these new medications was helping with their depression, they accidentally found that they worked remarkably well for anxiety. These are often prescribed first for anxiety disorders. And the antidepressants, such as the SSRIs, Paxil, Zoloft, Prozac,